Hello class, this is chapter 14 for your sports psychology course. It's designed to discuss applied exercise psychology, and let's get started. Exercise psychology is defined as the study of psychological factors underlining participation and adherence in physical activity programs. So be very careful not to confuse this information with Chapter 1. Chapter 1 in your textbook talks about sports psychology. This particular chapter, Chapter 14, talks about exercise psychology. So here are the three ways that these two different disciplines differ. First has to do with the nature of the population. Typically, exercise participants are associated with exercise psychology. Sports psychology focuses on elite level athletes. They also differ in the type of physical activity. Obviously, exercise psychology is looking at exercising, and sports psychology looks at sport or elite level competition or athletic competition. The third way that they differ is in the goals of the activity. Exercise psychology really is about improved health, physical appearance, and fitness versus optimal athletic performance and successful outcomes following competitive events. Both areas, however, do attempt to explain, describe, and predict behavior. Your book does a really good job of defining different areas in the field within exercise psychology. So just a few of them off of page 295 talks about exercise programming, examining positive versus negative addiction and commitment to exercise, identifying psychological benefits of regular exercise, exercising to improve quality of life and slow the aging process, using exercise in rehabilitation settings. All of these different components are what make up exercise psychology. And it's very important to understand and study these components because of the fact that we are experiencing an obesity epidemic within our country recently. So there is a growing need to understand reasons for these unhealthy trends, particularly related to explaining a person's sedentary lifestyle and studying effective interventions that promote exercise behavior. We do know that developing exercise habit begins with self-motivation. So the next few slides that you see here talk about the components. I picked out a couple specific ones for you, but your textbook lists a much more comprehensive list of the different components. So I'm going to go ahead and click through this. If you want to see these components in greater detail, again, they are in your textbook, but they're also in your PowerPoint if you'd like to take some more time to study these. Since we've already talked about them, I'm going to go ahead and click forward. As future healthcare professionals, I want to take a moment to talk with you about the state of mind and how the effects of exercise have, what they have on emotion and psychological benefits of exercise. Because it's very clear to us, the more that we study the obesity epidemic, people still choose to decide not to exercise. They want to watch TV, they decide to stop at McDonald's, they suffer from weight gain and poor health. So we attempt to understand why some individuals make these choices not to exercise or maybe to exercise, and why do some choose to quit. So without question, helping someone initiate and maintain a regularly scheduled habit of exercise, whether it's structured or whether they're working out on their own, is very challenging to all health and fitness professionals. So one of the ways that we could consider getting more people exercising and overcoming these dropout rates is to not only look at the research, but also to look at the results of the research and the acute and chronic effects of exercise. So I'd like to take a moment to point out a research study coming out of the Cooper's Aerobic Institute from Dallas from Drs. Stephen Blair and Suzanne Brodny. And they looked at 24 studies that examined links between the effects of aerobic exercise, on physiological outcomes and morbidity and mortality, so disease and death. And I think it's important to note that the findings stated three important things. Number one, that overweight and obese individuals who are active and fit have lower rates of disease and death than overweight and obese individuals who are inactive and unfit. Second point made in this study is that overweight or obese individuals who are active and fit are less likely to develop obesity-related chronic diseases and have early death than normal weight persons who lead sedentary lives. So they're less likely to have an early death. I read it probably a little misleading. But once again, overweight, obese individuals who are active and fit are less likely to develop obesity-related diseases or experience early death than normal weight persons who lead sedentary lives. That was really kind of flooring to me. And then the third important point to come out of this was inactivity and low cardiorespiratory fitness are as important predictors of mortality as being overweight or obese. So if any of you guys have heard the phrase smoking, sitting is the new smoking, that concept comes into play with that particular finding by Drs. Blair and Dr. Brodney. So what we have to take out of this and make sure that we communicate with our clients or our athletes is that engaging in aerobic forms of exercise is the most important factor contributing to good health and lowering the rate of disease. And instead of allowing individuals to focus on losing weight as the idea or the reason that's motivating them to exercise, helping them to kind of shift that focus so that they understand that they're exercising in order to promote health-related benefits of exercise, in hopes that that concept will help reduce the likelihood of them quitting. So something else that you can share with your individuals in regards to the positive effects of exercise are the acute exercise effects versus the chronic exercise effects. Remember, acute is short-term, chronic means long-term. So acute exercise effects shows that one bout of aerobic exercise in non-competitive environments can reduce negative effects such as aggression, anger, and hostility, and also it can increase their mood state to be more positive. Chronic exercise effects, typically if someone's performing 30-minute bouts of exercise for at least 4 to 6 weeks, we can also see an enhanced positive emotions within our athletes and clients. And listed for you here, you can see kind of a good bulleted information for you in regards to changes selected to someone's personality traits. There's improvement in self-esteem, improvement in their confidence and their self-sufficiency, a greater improvement in optimism and their elevated mood state, and also reduced trait and state anxiety. It's a lot of very, very good things that comes out of aerobic training. And while we want individuals to focus on the acute benefits of exercise, we also want them to understand that if they stick to it and if they remain active, that there are chronic adaptations that take place. So it talks about improving speed and efficiency of information. So perception is increased. Decision making, their memory storage and retrieval, especially among the elderly, can be enhanced. It slows the neural aging process. And elevates mood state, reducing chronic and acute stress and reducing mental fatigue. So lots of really good arrows pointing towards the importance of aerobic physical activity. The next portion of our lecture talks about psychology theories and models associated with exercise, and these help us understand the factors that contribute to and even predict some exercise behavior. So what's presented in this lecture talks about the most common theories and models in exercise psychology, and we're going to start that right now. So the first one in your textbook talks about the health belief model, and it posits that persons with the belief that certain behaviors will influence aspects of their life have an increased likelihood of engaging in those behaviors. It's actually an illness avoidance model in that someone's actions are guided by acting in ways that would reduce the chances of contracting a disease. So for an example, a person would specifically avoid smoking cigarettes because they know that smoking cigarettes would cause them probably more than likely to develop some sort of lung cancer. So this could also be another example would be exercising so that they don't become obese. So it's talking about anticipating undesirable health outcomes, and this will motivate people to avoid them or at least reduce the impact. So for this particular person, the reason to exercise is to prevent poor health, obesity, heart disease, and other chronic diseases associated with sedentary lifestyle. The health belief models actually received moderate, not extensive support by researchers. There is stronger support for younger individuals, not so much for older adults. Theories of reasoned action and planned behavior really looks around the concept that says that individuals have the greatest commitment to exercise when they hold favorable beliefs about exercise, but also believe that they can successfully perform the behavior. So this theory really focuses on personal intentions and something called perceived competence, and we'll get back to that in just a second. So a major question that researchers kind of form around these two theories is what influences people's decisions about their behavior in social settings. And the most important component of the theory is that an individual's intentions form the best predictors of actual behavior. So when they have a proper attitude toward exercise, this reflects in their beliefs about the benefits and also the consequences, whether they're positive and negative, of either engaging or not engaging in regular exercise. The second component talks about subjective social norms about the behavior. These norms reflect an individual's perceptions about the importance that others place on specific health behaviors and the person's incentive to meet others' expectations to follow these healthy habits. So, for example, someone that's actually surrounded by one or more friends or family members who habitually exercise is more likely to exercise regularly than individuals whose friends or family don't. So think about a time when you've actually gotten really involved in fitness. Did you really do it all by yourself, or did you do it because a friend got you into it, and then once you got there, you met somebody else and became friends with them? Think about when you first started this program. Did you really think about the concepts about what it meant to eat right and to be physically active? And did you start doing different things and changing your routine because you were surrounded with the information? So those are kind of good examples. And developing social skills as a part of exercise can result in better exercise adherence. So if you are trying to link yourself to exercise by hiring a personal trainer or trying to go work out with friends, or just simply having some time at the end of your workout to actually socialize, can kind of build exercise into your life. And this is kind of part of the theory in regards to theories of reasoned action and planned behavior. The third component of TRA is talking about perceived behavioral control. And that is an individual's perception that he or she has the resources and the opportunity to perform the behavior or actually to attain the goal. This is actually a new component in a follow-up study of TRA, and it basically talks about unrealistic expectations. If someone expects that they're going to have a huge improvement in their fitness and a significant weight reduction in a small amount of time, that's probably not going to give them a high perceived perception of control. So this is why when we study in class, we understand that anybody that's looking to lose weight and to leave it off permanently and to do it in a healthy fashion should have an expectation of no more than about 2 pounds per week. And that only changes if you've got someone that's severely obese and is drastically changing their eating styles or habits and exercise adherence. So an individual with unrealistic expectations, I want to lose 15 pounds in 1 week. As a result of that habit, can likely experience low perceived control, because what's going to happen? They're going to go, maybe they are going to eat really well and they'll work out really hard throughout the week, but they're probably not going to lose 15 pounds, and that's where that low perception of control comes in. Likewise, low expectations about future success can also result in quitting future exercise participation. So higher perceived behavioral control, which talks about setting realistic goals, good perception or a high perception of improved performance quality, especially early in the program, will support individuals that are within this theory. So how effective are the TRA and the TPB in predicting exercise behavior? Scientists actually concluded that improved exercise behavior does result when a person develops the intention to exercise. So what we must understand is that intention is strongly related to attitude with respect to exercise behavior. In studying this theory, we understand that there are 3 clear components of TRA that offer ways to encourage exercise participation and maintenance. And it has to do with attitude and subjective norm, which is talking about a person having to develop a favorable attitude toward exercise. Number 2, form the person's intention to exercise. So making sure that it's very helpful that exercisers develop social support. If you're working with someone that wants to be physically active, but they just kind of seem clueless and don't know how to do it, give them strategies for social support, somebody to help them to kind of lead them into the situation. And then finally, the third component is the perceived behavioral control. The exerciser should control all decisions surrounding the exercise program. So this could include the actual workout schedule, allow them to pick the day of the week and the time of the day, the location, where do they want to work out, how long do they want to work out for, and then also some of the program content. The bottom line is that a person who aspires to improve physical and mental health, to feel better, to have more energy, and enhance physical appearance has to have the initiative to make it happen. The one limitation that's presented with this particular theory is that a person may fully believe that exercise is very healthy, yet conclude that there's not enough time in the day to exercise regularly. So that tends to be a frequent excuse from individuals with heavy work schedules and also who tend to be overweight and sedentary. Okay, so moving on to self-determination theory. This is a very famous theory within psychology. Deci and Ryan proposed this in about 1985 that says individuals possess three primary psychosocial needs. The first is the need for autonomy, to be independent. The second is for a need to demonstrate competence. And the third is to demonstrate a need for social interactions or relatedness. So their basic concept behind self-determination theory is that people are motivated to seek challenges that satisfy one or more of these needs. So the three types of motivation that drive their achievement behavior, and this has to do with the intrinsic, extrinsic, and amotivation. So let's take an opportunity to really review what those three concepts are about. Intrinsic motivation occurs when the person exercises for pleasure or satisfaction. And this doesn't just have to apply to sports or athleticism. It could just be you have intrinsic motivation to do well in your studies. You are intrinsically motivated to make sure that your kids get out the door with, their backpack and their lunch and, their homework done for the day. So intrinsic comes from within. Extrinsic motivation drives any type of behavior, but for this class specifically exercise, based on different types of regulation. When the person is confirming a sense of self, in other words, I feel better about myself when I exercise. 2, achieving personal goals. 3, feeling a sense of obligation. I need to improve my health. I need to lose a couple pounds, to make sure that I'm strong and healthy in my aging life. And 4, to gain a reward or to avoid punishment. So this one really talks about outside motivation to get someone to perform a behavior. So this could be the woman that really wants to fit into that, size 2 dress for her high school reunion. So she's going to work really hard just to fit into that dress. Or someone that said, look, honey, I'll take you on a vacation to Barbados if you do lose that 20 pounds that you're working on. Those are all forms of extrinsic motivation. Amotivation is the relative absence of motivation or a lack of intention altogether to actually engage in exercise behavior. There's very limited research that supported the validity of self-determination theory to explain and predict exercise behavior, but again, Deci and Ryan, this is a famous theory in psychology that can be applied not only just for exercise but across the board. There is a really good opportunity for you guys to do some additional research on self-determination theory, and I encourage you guys to do that, especially by looking at peer-reviewed articles throughout the library. The theory for self-efficacy talks about having a set of beliefs and expectations about how capable someone feels in performing necessary behaviors to achieve a desirable outcome. So it's very specific to a behavior in a situation. Someone can have very high self-efficacy about their ability to lift weights, but actually feel very not confident when it comes to actually doing aerobic exercise, and vice versa. If you guys think of an example, the typical woman, when she goes to the gym, what does she do? She typically sticks to the aerobic side of the house and doesn't do a whole lot of weights. So that's kind of the example that I'm referring to. So a woman in exercising, especially any females that go to the gym, might have a very high self-efficacy about doing their cardio workout, but have very low self-efficacy when it comes to stepping onto the strength training side of the gym. Individuals who believe they're capable of performing the required actions to meet the situational demands will be more likely to engage in these actions. So think about a woman that believes that she's capable of doing a routine, back and bis, chest and tris. And if that's the case, then these expectations can do a couple different things. First, it can affect his or her selection of those activities. So is she going to walk in and decide just to do cardio and then leave? Or if she has high self-efficacy, is she going to choose to do her cardio and then go get some sets and reps in? It's also going to talk about the degree of effort expended in those activities. Is she going to spend a decent amount of time, or the extent to which she will persist at these activities, especially if she goes over there and let's say that she drops a weight accidentally, or maybe she felt like she was not performing the correct action and she felt embarrassed. So that would be an example of experiencing failure or an unpleasant consequence of not meeting the actions. With self-efficacy theory, we have to understand that exercisers who don't meet goals quickly will presume that it's unsurmountable and they will quit exercising altogether, probably because of low self-efficacy. So in the situation that we've been talking about with females resistance training, it's very important that they are able to suffer small successes in order to build self-efficacy to get them to commit to continue that type of exercise regimen. If self-efficacy is higher, this leads to greater likelihood of exercise participation and maintenance if a couple things happen. If they have perceived choice, in other words, they select the type of exercise behavior that's undertaken. Also, if they exercise for pleasure and enjoyment under conditions of high self-determination and competence and heightened self-control. Expending optimal effort and feeling capable of redoubling their efforts if they do have barriers that they have to face, and has reasonably high expectations of successful performance and desirable outcomes. The basis of self-efficacy theory is regarding performance accomplishments, and this is also something that I refer to as skill mastery. So if someone has accomplishments that they feel successful at, that is going to be the strongest influence, according to this theory, of self-efficacy on exercise behavior. So if you have a great run, what do you want to do? You want to go back and do it again. If you were a little bit nervous about walking into the free weight section of your gym and you went in there and you did 3 sets of let's see, shoulder curls or bicep curls, and you felt successful at it, that's going to want you to feel like you want to go back and be able to tackle that accomplishment later. So that's called mastering tasks, and the individual perceives the difficult markedly, and that will increase self-efficacy. Another theory that's extremely popular in psychology is called the trans-theoretical model. It's also called stages of change theory, and it's got considerable attention from researchers. So according to this model, the decision to begin and maintain a habit, such as a behavior change, occurs over a long period of time, and because the decision to change one's behavior isn't always permanent, like dieting or quitting smoking, or trying to begin an exercise regimen, is very cyclical. It's not linear because behavior patterns occur again and again. So we're going to go into the 6 stages of this particular model, and the stages are pre-contemplation, contemplation, preparation, action, maintenance, and termination. So let's jump into those. Pre-contemplation is when an inactive person has absolutely zero intention of exercise, probably within the realm of about 6 months. So this is your typical couch potato person who doesn't feel like they need to exercise. Maybe they haven't had good experiences in the gym or with the personal trainer or at any previous attempt. They just have zero intention. This person could be obese. This person could appear to be extremely healthy. Obesity doesn't really have a factor playing into pre-contemplation. The idea behind this stage and the theory of change is that they just simply don't desire to be physically active. Contemplation is now when they start thinking about exercising. They maybe have had a health scare, maybe their son or daughter or friend or cousin or uncle has now started exercising and is really enjoying a program. Something has sparked interest in this individual and they're thinking about getting started. So it can come from a whole range of different reasons that they would become interested in starting an exercise program. So again, pre-contemplation is no interest. Contemplation is now, I might be interested in starting, but I'm just going to think about it. And this can last anywhere up to 6 months. Preparation means that the individual is actually intending to take action in the near future, usually within a month. So this is when an individual has, seen their friend go to the CrossFit box. They've seen a friend go to maybe Pilates or maybe a kickboxing class, and they're interested, so what they're going to do is try to form some sort of action plan. And it might just be researching, calling facilities, checking out prices. Maybe it's just creating a spreadsheet of all the different locations that they could attend to do something physically active. So the individual isn't fully committed to the plan, but they're still thinking about the advantages versus the disadvantages. The next stage is when they're actually into it. It's the action phase. They've finally initiated an exercise routine. They've gone from not being interested to thinking about it to preparing for it, and now the next stage is actually doing something, and they've been exercising within about 6 months. So although an extensive amount of activity through scheduling exercise, thinking about advantages, actually going and working with someone maybe is now underway, it's actually the least stable stage. And it actually tends to correspond with the highest risk for relapse. And this stage, again, can endure from anywhere from 1 to 6 months. So think about it. People get into their exercise regimen. The first probably 2 or 3 weeks are the hardest. And people are very sore. They're like, why am I doing this? And then all of a sudden they hit a stride after week 4, 5, and 6 when they're actually enjoying it. It's come a part of their routine. And sometimes what do? Oh, I can take a day off. And then we have relapse because one day might turn into 2, and then 2 days might turn into 10. So this, again, the action phase of the trans-theoretical model tends to be the highest stage at risk for relapse. The maintenance phase comes after that period of work for 6 months, even if a relapse has occurred, and that's why we say that this model is cyclical. During the maintenance phase, there's actually less risk that the person will quit. There is a lot of uncertainty in the literature about the operational definition of maintenance, so it's very, very broad. But again, if action phase lasts 6 months, the maintenance phase is also starting after that 6-month period. So this is when they're working, it's become habit, and even if they've had a relapse, even if they've had 2 or 3 relapses, as long as they've gotten back into that phase, they're now in the maintenance phase. It's also referred to as partial adherence, ideal adherence, appropriate adherence, and this means that a person's decision to maintain exercise reflects the criterion under which the behavioral change was originally intended or planned in order to have that anticipated or desired outcome. So, for example, a person starts a 3-day per week exercise program, and after a few weeks, exercises only 1 day per week. So what happens? Health benefits, not as much as they could be. But because the person went from no exercise to once per week, it could reflect partial adherence and not necessarily full. So 5 years of continuously maintaining an exercise habit is a time interval in which a person will not return to their previous non-exercise lifestyle. It sounds like a long time, doesn't it? And that's what actually leads us to the final stage of the trans-theoretical model, is termination. And at this stage, there is zero temptation to engage in that old behavior that they were probably engaging in the pre-contemplation phase. And there's 100% confidence about overcoming previously tempting situations. So the trans-theoretical model forms a coherent structure from which to understand the reasons that underlie a person's decision to change or not change behavior, and to construct interventions that facilitate desirable changes. And in this case, it's to engage in a long-term exercise program. And a final thought about trans-theoretical model is that when you actually review the addiction literature, which is actually where the trans-theoretical model came from, it reveals that reverting to previous habits is always possible. As scientists, we can't ever rule something like that out. Given the presence of certain factors like maybe the high demands on time, maybe somebody gets hurt, maybe their social support has gone away for some reason, maybe they fail to meet a goal, maybe they have an increased exercise difficulty that they just can't surpass or overcome, or aging, or maybe even a lack of financial resources. So while we understand that termination is the final phase where it's the least likely to suffer a relapse, it is always possible. And again, that's why this particular model is cyclical in nature, not linear. So the final concluding statement about this, the theories and models within this chapter, is it talks about the validities of theories and models, and explaining and predicting exercise behavior is really kind of clouded by failing to recognize what type of exercise we're trying to encourage and measure. So it's different for everybody. So we, as exercise pre-professionals, and eventually professionals in the field, it's probably the best to simply encourage people, no matter what their situation is, elderly, overweight, maybe recovering from sickness or injury, to simply encourage them to engage in any type of exercise that they view as safe and mentally stimulating. And again, we're not focusing on the requirement of weight loss. We're focusing on it's good for your health. This is what will help elongate your life and give you quality of life, and not just time sitting in the nursing home. The next topic for our discussion talks about exercise adherence, exercise compliance, and barriers to understanding how we can help individuals avoid quitting, but also help them maintain an active lifestyle. So the first thing I want to talk about is exercise adherence versus compliance. The tendency of a person to maintain participation in any behavioral regimen, exercise in our case, once the individual has agreed to undertake it, is called exercise adherence. So this is sticking to it or faithfully conforming to a standard of behavior in order to meet a goal. So it's related to, here again, to achieving the goals, getting positive results, having that improved scores from pre-test to post-test if you're doing an assessment with that individual, providing them with social support, having improved time management. These could all be goals that would enhance exercise adherence. Compliance, on the other hand, is actually sometimes used interchangeably when there is a different definition. Compliance refers to behaviors related to following immediate or short-term advice, or a direct prescription to improve health or well-being, or a sense of coercive obedience to order. So this might be someone that has had quadruple bypass heart surgery, and their doctors prescribed that they need to do cardiac rehabilitation prior to simply returning to normal life. If someone were to attend and do their program through cardiac rehabilitation, that would be considered exercise compliance. So a person who initiates and maintains an exercise program of their own volition are adhering to rather than complying with their program. However, people who are given instructions about what exercise to do and how to do it and who to carry out these instructions with are complying with an exercise program. So what are some strategies for promoting exercise adherence? The first is to make sure that your client or individual understands realistic expectations. And we talked about this a second ago, but understanding that individuals should expect to lose no more than 2 pounds per week if their goal is weight loss. And this is the healthy way to keep excess weight off for the rest of their life. So saying someone wants to lose 10 pounds in 2 weeks isn't very realistic. Is it possible? Yes. Is it healthy? Probably not. So we want them to have realistic expectations to be able to be comfortable exercising and attempt to develop a habit before having any sort of weight loss or performance expectations. A simple strategy to help promote adherence would be to have them dress properly. So making sure that they're wearing the right footwear for exercise. If their feet aren't comfortable, they're going to have a hard time participating in an activity. Having the individual warm up properly. There really isn't a need to stretch prior to working out. Warming up would be doing cardio for 5 to 8 minutes, especially if you're someone that's just a weightlifter. If you just want to go and bang out some weights at the gym, you still need to do some sort of warm up. Do they always do it, gentlemen? No. Do they know that they need to do it? Probably. But some sort of engaging in light aerobic work that will slowly raise your heart rate, raise your core temperature, get you sweating a little bit, will prepare your body for more intense exertion. So now let's talk about stretching. Stretching, typically when people think of stretching, they want to do it before their activity, when actually research has shown that stretching is more appropriate post-exercise or post-workout. So instead of taking 20 minutes to stretch before your exercise, do your cardio first and then stretch after the workout. So we would want to use static positions where we hold the position for several seconds and avoid the bouncing type of stretching technique that can be very, very dangerous, especially for someone that hasn't stretched in a while or isn't practiced or taught the correct methods of stretching. Interval training, we also refer to this in exercise science as HIIT training, high intensity interval training. And the reason this is so great to promote exercise adherence is because it requires less time. So you want to use it for best results to not only improve aerobic fitness, it can reduce the unpleasant effects of the nonstop exertion. It promotes cardiovascular training with less exertion, and it allows for recovery from intense exercise. So it consists of alternative work to rest intervals. So let's say a good example would be a light aerobic warm-up. You engage in several bouts of work, 3 minutes of light jogging, and then rest interval sessions of 30 to 45 seconds between work bouts. So the difference between HIIT training and interval training that's described here in your book is that HIIT training, high intensity, actually has the individual work harder. For instead of doing 3 minutes of light jogging, they might do 60 seconds of an all-out sprint and then have 60 seconds of a rest interval. Obviously, with sedentary individuals, you would want to perform the interval training with them first, where it was light work and then a good rest to work ratio. If someone is physically active, if they're very fit and they've been in the gym before, they've had prior experience working out, then a high intensity interval training would probably be the right way to go for them to see cardiovascular benefits for them in there and adaptations to take place within their body. So that's why the last sentence here says fitter persons can exercise more intensely with longer and more difficult work bouts. So the point is we need to make sure that we're involving some sort of fitness professional to guide these type of training sessions based on who the individual is and what their background is. Whether it's HIIT or IT workouts, high intensity or just simply interval training, it can help adherence because the workout sessions tend to be less of a time commitment than, say, going out and doing 30 minutes of cardiovascular exercise at 75% of your heart rate max. For individuals that really complain about not having the time to work out, interval training is definitely the way to go. And we know that because the ACSM recommends 150 minutes of cardiovascular activity per week, or if you're going to, that's for moderate activity, or you could shorten that time to 75 minutes per week with vigorous training. Another way to promote exercise adherence, again, is to provide instruction about exercise and their feedback. So we've all seen people that are in the gym and we wonder what the heck that they're doing. They have improper technique. So what we can do to help them keep working out is simply help them to learn proper technique, to build their confidence, and to build their feelings of achievement. And that's also what provides individuals with intrinsic motivation to continue on. We also want to encourage social support. We've heard throughout this chapter so far that the people that surround themselves in the workout environment, in healthy lifestyles, with a support system, will really is a high predictor of exercise adherence. So we want to encourage people to go to the gym with their friends, or being around someone who is a voice of support for their new exercise habit. Also to educate the individuals, not just help them learn proper technique, but provide some peer-reviewed research articles so that individuals can read on their own to understand what it means to be an informed exercise individual. So give them written materials from appropriate professional organizations such as the ACSM, the NASM, the NSCA, that talk about proper technique and scientific principles of exercising properly. And then also encourage healthy lifestyle changes. We have to remember that exercise is only one component of several health-related habits that need to be incorporated for a person to have a healthy lifestyle. So exercising is just one piece of the puzzle. They have to, or not have to, but they should, consider proper diet and nutrition, increased hydration, getting the appropriate amount of sleep at night, and also proper management of stress and anxiety. All of those things put together, it kind of makes up a healthy lifestyle. So we need to make sure that we also educate individuals, and if we do, that could also help them increase their adherence to their exercise program. Another suggestion from your textbook talks about the role of faith and spiritual beliefs in developing healthy habits. There's actually an extensive body of research that supports the role of faith as a source of inspiration and justification in maintaining a healthy lifestyle. Of course, that's a personal choice, but a person's religious beliefs and spiritual feelings usually have strong motivational value related to a healthy lifestyle. In order for us to really encourage adherence through the strategies that we just talked about, we also have to understand primary perceived exercise barriers. And I don't think this is hard for any of us to imagine what certain barriers would be. We've all given reasons as to why we can't get into the gym or can't be physically active for the week. But we say perceived because these perceived barriers are based on an individual's personal explanations, but more importantly, interpretation of reasons for not exercising. So these perceptions may not necessarily, in fact, be based on reality. So a lot of barriers that we hear sometimes is, and very frequently the first one is, I don't have time to do it. I have my family, I have my school, I have my job, I have my mother, father, brother, sister that I have to take care of. Lack of time tends to be the most common perceived exercise barrier. Another barrier is that they don't have the right equipment or an available facility, or maybe it's too expensive to attend a certain facility. Individuals might also claim that they don't understand how to use the equipment, so they're just not going to do it. There's also lack of social support. High self-consciousness. Typically, individuals that are obese are very, very aware about perception of themselves from individuals as they go throughout their day, especially in the gym. And if you go to certain gyms in certain parts of town, you're going to see individuals that are sleek and beautiful and they're working out really hard 5 days a week. And then you've got other facilities that, kind of base themselves around the fact that this is for your average everyday Joe, come on in. So high self-consciousness, whether it be obese or whether it be someone that is very concerned about the way that they look when they lift weights. Maybe they're not confident in that. That can be a barrier to someone walking into a gym or trying to be physically active. They're worried about what people will think of them, what perceptions will be if they try to be physically active. Another barrier is you might be in pain. Pain typically indicates there's injury present, and obviously we would want someone to visit their local medical facility or their primary care physician to get that addressed. That is absolutely something that needs to be addressed. If you are a healthcare provider and someone is complaining of pain, the first response is, well, why don't we get you to a doctor and let's see what the doctor says before you continue. You want to make sure that you take that liability off your back. Another barrier is lack of convenient exercise location, and there also might be poor exercise environment or neighborhood. Maybe someone lives in an area where there aren't sidewalks. I lived in Cocoa Beach for a while, and they're just now building sidewalks up and down the streets. But it might just be a poor exercise environment. Maybe someone lives in a very low socioeconomic area where they can't go out after dark because it's too dangerous. All of these are perceived barriers that we need to be aware of. So some of the things that we can do for cognitive behavioral interventions really talks about providing strategies to get them to get around those barriers. And I've included a podcast if you have time and you would like to. I'm not going to bring it up now, but I believe it's only a 3-minute podcast that's very interesting related to cognitive behavioral interventions. But cognitive strategies that we can take with our clients deals with imagery, positive self-talk, psyching up, positive association, disassociation with negative behaviors, anticipation, thought stopping, and planning. Some behavioral strategies that we can use to intervene to maybe prevent barriers from someone working out or being active would be goal setting, helping an individual understand how to set smart goals to make sure that they're attainable and that they're realistic. Light exercise, in other words, maybe mixing up working 30 minutes for cardio one day and then doing an interval training session the next day. Incorporating music into the activity. Information seeking, social support, self-monitoring, record keeping is another big one, especially if you have individuals that need to see improvement. Recording your pre-test assessments and then recording the successes or the record of action, completing 30 minutes and you weigh yourself every Tuesday. Allowing someone to see their progress, whether it's through a chart, whether it's through a graph, can be very effective. And then also social engineering, having them incorporate a friend or a group of peers during their workout. These are all ways that we can overcome barriers for sedentary excuses. Now we're going to switch gears because typically in class we discuss sedentary populations and individuals that don't get off the couch and strategies to help people get physically active. But now we're going to talk about individuals that maybe exercise too much. So we're going to talk about the difference between exercise addiction and exercise dependence. The antithesis of the problem of getting people to exercise, in other words, to adhere to an exercise habit, is the problem of people who become dependent on it. And this is typically called exercise addiction or exercise dependence. So is exercise addiction really a bad thing? And most researchers tend to agree that addictions in general tend to be unhealthy and undesirable, because they represent behaviors that are beyond the person's control or that reflect psychopathologies. So low self-esteem, possibly an eating disorder, a mental illness. So for an example, exercise motivation studies indicate that one incentive to engage in a running or weight training program is to improve body image, which is a fundamental part of self-esteem, and that's a personality trait. And while there's nothing wrong with linking an exercise habit to improve physique, sometimes an individual will devote a huge amount of time to exercise at the expense of other normal routines and social interactions. So this preoccupation with exercise is considered abnormal or actually dysfunctional behavior. And although the compulsion to exercise may have a positive anabolic, which means tissue building, effect on the body, that would be positive addiction, exercising excessively has the reverse effect. It's catabolic, which means it's tissue destroying effect on the system. And this would come with negative consequences as a result. So as a term, this is called negative addiction because injury, illness can lead to negative consequences. Additionally, in regards to a positive addiction, as long as a person's exercise compulsion is beneficial to his or her health and psychological well-being, the addiction or the dependence may be called positive. The change from positive to negative exercise addiction occurs when the person becomes compulsive about an exercise routine at the exclusion of other daily activities. In other words, somebody must exercise rather than for exercising for improved health or relaxation or other forms of enjoyment. This person typically considers exercise as a central point of life, even at the expense of health and life satisfaction. So that's the difference between positive and negative addiction. Some ways that you can tell or you can kind of suspect if someone is dependent on exercise are as follows. Tolerance. Someone has a need for more exercise in order to achieve a desired effect. So you notice someone will be spending longer and longer time working out. They also might be suffering from withdrawal symptoms. Maybe they have heightened anxiety. Of course, if they're spending longer time in the gym, they're probably going to be experiencing some sort of fatigue or disturbed sleep patterns if they miss their exercise routine. Intention effects. Exercise actually lasts longer than was originally intended. Oops, I felt great, so I just kept going. A loss of control. There's some sort of persistent desire or an unsuccessful effort to control exercise. Time, again, excessive amounts of time spent in activities needing to obtain exercise benefits. Conflict, starting to give up important social events or occupational or relationship activities because of their dependence on exercise. And continuance, exercise is maintained in spite of knowledge that it's problematic, either physically or mentally. And that's probably a really big red flag, ladies and gentlemen, is when you have an individual that is aware that it might be a problem, but they continue to follow the same behavior patterns over and over again despite their working knowledge of it. And sometimes you'll see this a lot with athletes. They have an injury or something hurts, and it's tougher to stick it out and work through the pain when it's leading you down a path that's going to lead you to very severe consequences. So what we want individuals to understand is that there has to be a balance between both. Exercise is good for you, but obviously, like anything else, too much of something can definitely be a bad thing. So in regards to exercise and mental health, what we want individuals, we want society, and we want the public to understand the benefits between acute and chronic exercise. And we touched upon these things a little bit at the beginning of the chapter. So we want everyone to understand that acute exercise in the short term, can reduce state anxiety. Chronic exercise that becomes a habit that you perform again and again, even with relapses here and there, can reduce things like clinical depression, can reduce chronic anxiety, it raises your self-esteem, it can reduce feelings of helplessness and hopelessness, and overall promotes a feeling of self-control. So as you're working with individuals, in your externships and eventually out into your profession, we want to understand the benefits of exercise, but we also want to be very aware if we see warning signals or red flags pop up with individuals when it comes to being addicted to exercise. Again, I would encourage you to look over the key points at the end of your chapter relating to applied exercise psychology, an emergent area in sports psychology. This will help you in your studies and in your preparation for your quiz this week. As always, if you have any questions, please feel free to call me, text me, or email me. And that concludes our lecture for Chapter 14.